Here's a presentation for week 1 on Introduction to Anesthesia. As the textbook points out, anesthesia is used almost daily in most veterinary practices to provide sedation, tranquilization, immobility, muscle relaxation, unconsciousness, and very significantly, pain control. Your textbook goes through some of the information on human anesthesia, where much of what we use today was developed. Some of the big names you'll understand and come across are William Norton, Morton was the big American person who basically came up with what we now know as modern anesthesia in this country. Holmes, several other people were along in England. Simpson was a big guy. So there's lots of people that contributed to the advent of anesthesia. The real breakthrough came in 1846 with the use of diethyl ether. Good old ether worked wonders for alleviating pain, and we have been moving down that road ever since. In the 1850s, ether and chloroform both became popular for use as inhalant anesthetics. In the early 20th century, inhalant anesthesia was often the method of choice, using ether and chloroform. And by the 1930s, injectable barbiturates became much more popular. They seem to provide greater safety and less consequences than ether and chloroform, so they became much more popular. Anesthesia itself is just basically the loss of sensation. We use either central nervous system depression or central nervous system stimulation to produce that loss of sensation. Certainly we're going to use a lot of anesthesia in veterinary medicine. The effects we are looking for are either sedation or tranquilization or immobility or muscle relaxation or unconsciousness or pain control. We do that and seek those effects so that we can do surgeries, dentistries, in some cases grooming, and I'm sure you've met some of those lovely little dogs that needed to be virtually completely anesthetized to handle, even for the most basic grooming procedures, little land sharks. Diagnostic imaging, wound care, capture and transport of wild animals. General anesthesia is and should be reversible. It is produced by the administration of one or more anesthetic drugs, and it has some specific and very hopefully predictable characteristics. Surgical anesthesia is a stage of general anesthesia. We have analgesia and muscle relaxation, and the purpose of surgical anesthesia, as it would be logical to assume, is to eliminate pain and patient movement during surgical procedures. There is a continuum of CNS depression. This is a chart from your book with some very good and important terms to use. On the left, we have the levels of consciousness. In the middle, we have some terms that you'll probably need to know, such as sedation, hypnosis, narcosis. And on the right side, that shows the difference between just simply being sedated and having general anesthesia. It is considered bad to perform general anesthesia when we only would need to sedate a patient for a procedure, and it's even worse if you sedate a patient and they need general anesthesia. We do try to avoid all that painful stuff. Sedation versus tranquilization. Well, with sedation, there's going to be central nervous system depression. There'll be drowsiness. It is drug-induced. You have to give them something to produce sedation. It comes in various levels. They can be a little sedated, they can be a middle sedated, they can be heavily sedated. They may be slightly aware or can become, in heavy sedation, totally unaware of their surroundings. They can be roused by noxious stimulation, which usually means anywhere from a loud noise to something that's painful. And sedation is good for minor procedures, things that are particularly not painful. Tranquilization produces calmness. The patient is reluctant to move. They are aware of their surroundings, but basically they just don't really care much about what's going on. Hypnosis is a drug-induced, again we have to use drugs, sleep-like state that impairs the patient's ability to respond to stimuli. And with hypnosis, the patient can be aroused with sufficient stimulation, auditory, pain, physical stimulation. Narcosis is a drug-induced sleep. The patient is not easily aroused, and it is usually associated with narcotic drugs, usually the opioid class of pharmaceuticals. Local anesthesia certainly plays a role in our profession and should play a role in our profession. Local anesthesia targets a small, specific area of the body, and most of us are familiar with the concept of local. Loss of sensation is then produced in that specific area, depending on size, and a drug, such as lidocaine or bupivacaine, is infiltrated into the desired area to produce the local anesthesia. Topical anesthesia is applied to a body surface or to a wound and will produce a superficial loss of sensation. Topical anesthesia, much more commonly used in human medicine than particularly it is in veterinary medicine. Regional anesthesia is the loss of sensation to a limited area of the body, usually a lot larger than we would produce with a simple local. We often use nerve blocks, particularly in large animal medicine, or in small animal medicine, an example would be epidural anesthesia that will produce a regional anesthetic effect. Balanced anesthesia is the concept of using multiple drugs in smaller quantities. You don't want to use a whole lot of one thing, you want to use a little bit of a lot of things. It maximizes the benefits of each individual drug that is being used. It minimizes any adverse effects of those drugs. One big drug produces a lot of adverse effect. A little bit of a lot of drugs produces minimal effects. It's much safer. Balanced anesthesia is much safer, and it's much more effective for patients than just giving one big, huge dose of one thing. And it gives the anesthetist or the anesthesiologist greater control over that patient and over the procedure that's being performed. What is your role as a veterinary technician, as the anesthetist? Well, number one, you need to prepare, operate, and maintain your anesthetic machine. If that machine has problems, you're going to have problems, and the patient is going to have problems. It'll be your job to administer appropriate anesthetic agents. Then once the patient is induced, to then perform endotracheal intubation, and I do strongly suggest that you administer the anesthetic before you start trying to pass endotracheal tubes. Yes, I have seen students simply give the pre-anesthetic agents and then immediately try to intubate the patient. It did not go well, and they learned that lesson very quickly. And then once the patient is induced and stable, then you'll be responsible for monitoring the anesthetic parameters as well as the physiological parameters of that patient. Certainly there are going to be some challenges and risks. There are always risks. It will be important to know how to do dose calculation and rate adjustment. You'll need to know how to monitor vital signs and assess the anesthetic depth and physiological status of that patient. You're going to have to assess multiple, often conflictory pieces of information on a steady stream. You'll have to manage that patient with style and skill and grace, and be prepared and respond appropriately to any anesthetic accidents. And we often have a very narrow therapeutic index. You give a little and nothing happens. You give just a little bit too much and bad things happen. And then your job is to thread the needle and give just the right amount, not too much, not too little, to get exactly the effect you want. Certainly the drugs we're going to provide will cause changes in cardiovascular and pulmonary systems. Those changes, if not closely monitored and appropriately dealt with, can be lethal to the patient. Everyone gets scared about anesthesia. I don't want you to be scared about anesthesia. I want you to be concerned and vigilant. If you do your job, if you know what you're doing, if you're careful, if you're conscientious, if you are a caring anesthetist, things are going to go well. If you're not, if you take it for granted, if you don't pay attention, if you don't know what you're doing, and if you're apathetic and uncaring, then eventually bad things are going to happen, and it's not going to be the patient's fault. It's not going to be the anesthetic agent's fault. It's not going to be the machine's fault. It's going to probably be our fault. You're going to have to be assessing multiple pieces of information. You have to be visual. You have to be tactile, hands-on. You have to pay attention with your ears, auditory, sometimes olfactory. You have to pay attention to the things you're smelling. You are going to get a lot of information from the patient, from machines, from monitors, and with all this information coming in, you're going to have to be able to make rapid, accurate, knowing decisions. You're going to have to understand the physical parameters. And through this class and other classes, we will reinforce the need to understand the physical parameters of that patient. You have to know how their body is working. You have to understand your anesthetic equipment. You have to understand your monitoring devices, not just how to hook them up and stare at them in a mindless kind of numb way, but what they are telling you and how that has to fit with what you're seeing, both in your anesthetic equipment and most significantly with the physiological parameters of that patient. Take all that information, integrate it into one comprehensive picture, and then use that to monitor your patient. I do not believe there is such a thing as an anesthetic accident. I believe there are things that occur that we should have anticipated or handled that have bad outcomes. There are no accidents. There are only mistakes. And if there is, quote unquote, an anesthetic accident, you need to go back and find out who made the mistake and where. The outcome can be devastating or lethal. Certainly owners will most likely cause a big stink and may pursue legal action. We prevent accidents. We prevent mistakes by using high standards. And one of my real disappointments often in this class is the poor standard set by many practices. If we, our thing is if 9 out of 10 of them live, boy, we must be doing pretty good. That's not so bad after all. Unless your pet's the 1 out of 10 that didn't make it. And we need to keep records. Everybody hates paperwork, but paperwork is the grease that ensures our competence. Certainly workplace safety is going to be one of the most important ideas and concepts we need to maintain throughout this class. Veterinary technicians must be familiar with the human safety considerations involved in veterinary anesthesia. It's not just the animals. It has to be you as well. These agents are toxic. They will hurt you, and so you have to be careful. Anesthetic gases are a hazard to your health. Sources of waste inhalant anesthetic gas are those that are exhaled by the patient or escape from anesthetic machine during the anesthetic period. They can be inhaled when emptying or filling anesthetic vaporizers. They may be inhaled after an accidental anesthetic spill. There's lots of ways to get anesthetic gases. I'm not saying one whiff of anesthetic gas is going to cause terrible, catastrophic results in your body. But I'm saying if you inhale these things in a long period of time in fairly high concentrations, you're going to know about it, and you're not going to be happy with the results. We measure waste anesthetic gases in parts per million, and we have to monitor that. We have to take precautions. It will hurt you and those around you. The effect of short-term exposure to high levels of waste anesthetic gases, well, there's a direct effect of the anesthetic agent on your brain neurons. Duh. Resolves spontaneously when the area is left, like if you break a bottle of isoflurane or sevoflurane. And frequent occurrence indicates excessive waste anesthetic gas levels. If you're getting bad effects on a consistent basis, you're getting exposure somewhere you shouldn't be getting exposure. And then there are long-term effects of exposure to high levels of anesthetic waste gases. There are serious health problems. Reproductive problems, liver problems, hematological problems, oncogenic. I mean, we run the risk of cancers. Wipe out your kidneys, wipe out your neurons, wipe out your brain. These guys will hurt you. It's not good. May be the result, well, they almost always are the result of toxic metabolites produced by the liver. And anesthetics are eliminated through the lungs are less likely to produce long-term effects than, say, injectables. But don't assume that because it's not an injectable, well, a little bit's good. None is good. The reproductive risks include the risk of spontaneous abortion, infertility, congenital anomalies in the fetus and in the child. Oncogenic effects include none of the commonly associated agents are associated with increased risk of developing cancer at this point. There has been some research that indicate that may or may not be true. I'm just not going to take a chance. If it comes to getting cancer, I'm going to err on the side of safety. Let me tell you that real quick. These are, to a degree, hepatotoxic. It is not common, but with some inhalants, there are, such as a halothane, there is hepatic consequences to these guys. They can hurt your liver. We can run into renal effects. We can run into neurological effects, such as possible loss of motor skills, short-term memory, possible increased risk of neurological diseases. Okay? I mean, it's just bad. And then hematological effects, possible bone marrow abnormalities. There's not a lot of research in a lot of these guys. People just suppose, they hope. Most people don't want to volunteer to breathe a lot of anesthetic gases to see if it'll wipe out their bone marrow. Just not something everybody sign up for every day. The highest levels of waste anesthetic gases are generally going to be in the surgical suites, in the prep areas, and in the recovery rooms, because that's where the anesthetics are. The highest levels will be during the anesthetic period, and they're going to be nearest the anesthetic machine, because that's where all the anesthetic is. Factors that would determine the levels, of course, will determine how long we go through anesthesia, the duration, the flow rate of the carrier gas. The more oxygen that's going through, the more exposure you're probably going to have to anesthetic gases. Maintenance of the machines, an effective scavenging system, the type of technique that's being used, room ventilation, and we want 15 to 20 air changes per hour. That would be ideal. And then the presence of any anesthetic spills. Obviously, if you spill a whole bottle of isoflurane or sevoflurane right at your feet, you're going to get a big exposure. If you don't do that, then you won't. You need to use the scavenging system. And a scavenging system collects waste gas from the anesthetic machine and conducts it to a disposal site outside the building. This is the gold standard. This is the way to prevent exposure to anesthetic gases. Installation and consistent use are extremely important. You need to include exhaust from the anesthetic machine, non-rebreathing systems, ventilators, anesthetic chambers, capnometers. Everything should go. There are active or passive systems, and the active system with a dedicated pump is the most efficient. It's going to suck the gas out of the room. Passive system is certainly the least expensive and is best used in rooms with exterior walls. Two diagrams from your book showing the difference between an active and a passive system. On the left is an active system. We have a vacuum generator. It sucks everything out. On the right, we have a passive system where we just hope that with the gravity and a little bit of breeze outside that it gets pulled out of the room and doesn't back up into your lungs and brain. As with everything in life, there are potential difficulties with scavenging systems. We need to prevent the negative or vacuum pressure on the breathing circuit being too much, because if it is too high a vacuum, the reservoir bag will collapse and negative pressure relief valve will open. So we don't want too much of a draw on it, just enough to get the gas flowing, continue flowing that way. And obstructions may block waste gas from entering the scavenging system. Anesthetic gases will accumulate in the circuit. Excessive pressure can develop in that circuit in the patient's lungs, and at that point the positive pressure relief valve will open. So we don't want to block up the system. Okay, if you block up the system, bad things happen. The alternative to scavenging systems are the activated charcoal cartridges, which we see very frequently. These are used in rooms not set up for scavenging. The activated charcoal will absorb the anesthetic vapors, and you may be familiar with these. Your practice may be using them. You need to replace the cartridge every 12 hours or when the weight increases 50 grams. They don't absorb nitrous oxide vapors, which is not a big deal because nobody uses nitrous oxide anymore. And it is inefficient at flow rates less than 2 liters per minute. I'm not a big fan of our activated charcoal cartridges not because they don't work, but because people don't use them properly. And, they hook one up and think it's good for the life of the anesthesia machine. And 20 years later, they're still using the same activated charcoal filter, which is no longer viable or functional. There are masks that can be worn by personnel at special risk, particularly people that may be pregnant or have other health problems. They are not effective for nitrous oxide. Nobody uses nitrous oxide. And we don't use masks designed for particulate matter. We use gas designed for air and vapor. There are a lot of simple things that can be done to reduce the exposure to waste anesthetic gases. Check the equipment for leaks. If it's leaking, yeah, you're going to get exposure. If it's not leaking, you're probably not. Common sites for leaking equipment, the nitrous oxide connectors are not securely tightened. Rings, washers, seals, joining tanks to machine, hanger yokes are worn, missing, lost, non-functional, covered with mold, who knows. Covering of the unidirectional valve on the anesthetic machine is not tightly closed. That will leak. The carbon dioxide absorber is not securely sealed and closed. That will produce a leak. The pop-off or scavenger system is not airtight. There you go. Lots of leaks. Hoses are loose connectors for breathing hoses, reservoir bag, ET hole tubes. If you got a hole in something, it's going to leak. And the vaporizer cap is missing, and I've seen people do that. Take the cap off the vaporizer, fill it up with isoflurane, forget to put the cap back on. Just not seal it back up. And about the first time you hit that O2 flush, you're going to have anesthesia flying all over the room. It looks like a fountain. We certainly want to occasionally do a leak test, and that will be one of the emphasis of this course. There are high pressure tests. We check for leaks between the gas tanks and the flow meter. Gas pressure should be greater than or equal to 50 psi. Only oxygen or nitrous oxide, is released through any of these leaks. We don't really worry about it. Oxygen is not a big deal. If you are still using nitrous oxide, and I don't know anybody does, that would be a real concern because nitrous is not good stuff to breathe. Low pressure leak tests are done to check for leaks in the anesthetic machine and in the anesthetic breathing circuit. In this case, the gas pressure is less than or equal to 15 psi. Oxygen, nitrous oxide, and the anesthetic gases are released through the leaks. If you don't have any leaks, you're not going to have any exposure. If you have a leak, you're going to have exposure. If you check and you don't have any leaks, you're fine. If you check and you have a leak, then you need to fix the leak. What type of leak test to perform? Well, high pressure and low pressure. We're checking both for nitrous oxide and oxygen. Low pressure test alone, we're just checking for the oxygen carrier gas by itself, isoflurane, sevoflurane. We should run a low pressure test on every machine every day before it is used. High pressure tests usually run weekly or more commonly when tanks are changed. Especially if you're not using nitrous, it's not that big a concern. Leaks can be found by locating a hissing of escaping air or by using a detergent solution. Spray a detergent solution on the machine. That way, if it bubbles and you see like a tire, if you've ever seen tires being fixed, they'll put them in a detergent solution. A leak makes little bubbles there. That's a good way to know. Don't use the machine with a leak until the source of the leak has been identified and repaired. Okay, if it's leaking, don't use it. Certainly important considerations would be if somebody's pregnant. You don't want pregnant people around anesthetic and inhalant gases. It's a concern if you keep smelling the stuff. If you keep smelling ISO or SIVO, that's tells you something right there. Special concerns about waste gas levels. If there's anything else going on besides people being pregnant or you just don't want to wipe out all your neurons, you need to be careful. There are accredited industry hygiene laboratories that will come in and do professional monitoring. In very large hospitals, university hospitals, those kind of things, do those, and they're well worth the money. And certainly there are detector tubes or badge dosimeters that will detect the presence of anesthetic gases. So if you're working in a REG hospital, a specialty practice, someplace where you're doing anesthesia all day, every day, you need to be careful. even if you're not, even if you're just working in a general practice. Don't get sloppy. Certainly, we're going to be handling compressed gases. I need to be careful with these guys. They're dangerous. There is a fire safety issue. Oxygen and nitrous oxide will support combustion. They burn and they blow up. Static electricity can cause fires when oxygen and combustibles are present. You know that. And eliminate all sources of ignition or flames from any rooms where cylinders are stored or used. And yes, I have literally seen people stand by an oxygen tank and light up a cigarette. And you just want to shoot them. But you can't shoot them because the bullet might cause a spark and you blow them up. But use some common sense. These guys are dangerous. Just because it hadn't blown up in your face today doesn't mean it might not do it. Use and storage of cylinders. Cylinders are storehouses of large, sometimes almost unbelievable amounts of energy. You need to wear impact-resistant goggles when connecting cylinders to anesthetic machines. You need to turn valves slowly and use the proper wrench and tools when turning on the cylinder. You need to chain or belt these cylinders to the wall. Don't use duct tape like I've seen done before. Store in an upright position to prevent damage. Don't lay them down. Store them standing up. Store cylinders away from high traffic areas. Don't drag or roll a cylinder that can damage it. Keep full and empty cylinders separate. That comes in real handy when you try to change cylinders and you realize you just changed an empty cylinder for another empty cylinder and your patient has no oxygen. Use tear-off labels. Those work great, or some system that's pretty much foolproof. And try to use cylinders in the order they are received. If they come in first, then they're going to be used last, and so on. Good example, here's this little cylinder on its yoke. We know it's full because the bottom tag says full. Once we turn it on, we tear off the full, and we know it's in surface. And then once it's exhausted or to the point we don't want to use it anymore, we tear off in service, and we know it's empty enough. We don't worry that much about the accidental exposure to injectable agents in our profession. One of the biggest ones is certainly opioids, and opioids are used occasionally for the restraint and capture of wild animals. Inorphine and some others, immobilum, Wilnil, Wildnil, however you want to pronounce it, are used. These guys are far more important than morphine. They are absorbed through mucous membranes, broken skin, accidental injections, oral injections. There's all kinds of, if it gets in or on your body, these guys are terrible. They can be deadly in large enough amounts. Make sure that you know and understand any potent opioids if you're doing wild animal capture before using them. Do never work alone. Wear gloves. If you have, well, no, not if you have your reversal agents drawn up and ready for use. Have a treatment plan in place. Make sure you understand what could happen and how to treat it. And make sure you dispose of needles and syringes in a closed container immediately. Don't leave them laying around for somebody to accidentally inject themselves. Some of the others we use of not as great a consideration: the cyclohexamines, the alpha-2 agonists, ketamine, taletamine, xylazine, ditomidine, metidotomidine, dexmedetomidine. All these guys, if you get them injected, if you splash them, if you inhale them, if you decide to drink them, I don't care, if you're exposed to them, it's going to be a problem. And again, for precautions, we can't overemphasize the need for personal protective equipment. Carefully load your syringes. Carefully dispose of syringes and needles. Don't do stupid stuff. And have first aid, including eye washes and other treatment areas, available. Know what you're doing and don't mess up. And that will conclude the information on the Thomas and Lerche Text 4, Week 1. Don't do stupid stuff, okay? Life is short. Don't go through life doing stupid stuff needlessly. That's what bothers me. People do it sometimes so needlessly, when it's just as easy to do it right to begin with. Okay, I quit.